Hello, Sandy McFarlane is my name. Paula Davovich has asked me to speak to you of something we experience and the issues in talking to people who've been exposed to traumatic stress. I'd like to begin by highlighting that this is an area where clinicians across mental health professions do not have a good track record. Until the 1970s, the issue of trauma and sexual abuse was largely ignored by all of the mental health professionals. And in retrospect, I think it's a fascinating question as to how this came to pass and what it teaches us about clinical practice today. For example, the main textbook in psychiatry in 1975, Friedman, Kaplan and Sadok, said that the prevalence of incest was 1 in a million. Now we know that the rates are more in the order of 2 to 3% of the population, and the rates of sexual abuse are significantly higher than that from other individuals known to a child. So it's extraordinary that these patients would have gone along complaining of these issues and it wasn't documented. We equally know that DSM-3R, which was the second version of the current diagnostic and statistical manual that has specific diagnostic criteria that included PTSD, described a traumatic event that was one outside the range of normal human experience. Modern epidemiology, which very carefully probes these matters, shows that in fact more than 50% of the population has been exposed to one of these events. So what does that tell us? It tells us, A, that patients have a great deal of difficulty in speaking about these things, but equally clinicians have major difficulties in hearing what is being said to them. And I think we need to recognise that avoidance is one of the primary psychological strategies that people try to use to stop themselves having to recall and recollect these events. And equally there's a sense of horror and not wanting to know, and a conspiracy of silence that has often pervaded these areas. The other side of it is that I consult with many police officers, and in New South Wales they have a system which they call well checks. Here a clinician will inquire as to the exposures an officer has had and get them to elucidate the nature of the reactions they've had to those events. Officers complain vehemently about this process because of the naivety of the questions and the way that they're spoken to. And they are aware of the inability of the counsellors to hear what they're saying, and equally sometimes the counsellors become almost voyeuristic about the matters and the incidents that officers have had to attend. And that clearly is a major issue which is going to discourage the individual to disclose what they've had to endure. So this is a very interesting sort of dance between the patient's perception and monitoring of how they're being listened to, and equally the ability of the clinician to hear. One of the things that I would suggest is critical is imaginative engagement. One of the fascinating things about traumatic events is there's often a silence about them. These are not events that are well encapsulated and developed in language. Patients often will have the smells, the sounds, they are unseriated, unintegrated perceptual memories that haven't really been transformed fully into a verbal narrative. And that is one of the reasons why they're so troubling and stay in the individual's mind and recur in these intrusive and distressing ways. Equally, I think language is not well developed to explain or capture the emotions associated with some of these events. I'll never forget getting a textbook of emotion that was published by one of the big publishing houses in the US that I was asked to review. This was a book that was about 500 A4 pages, And I looked up the word horror in the index, and there was a single entry, and that was in the diagnostic criteria for PTSD. So it's a fascinating issue that horror is such an unstudied emotion. And I think it tells you something about how clinicians don't want to hear or think about it. Is horror fear? Is horror disgust? I think Shakespeare understood this. When Macbeth killed King Duncan and his guards, the person to come across this gruesome and horrific scene was Macduff. As a 16-year-old, I played that role, and I often thought about these lines, and I only wish I could go back and play the part again, because he ran down the stairs having discovered the bodies, crying, "Oh horror, 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 tongue nor heart can conceive nor name thee." And I think Shakespeare very clearly understood how these were events that were very difficult to integrate and to find words to describe. One of the other really interesting things is that when a person develops post-traumatic stress disorder, this is a disorder which has a very well-studied neurobiology, and one important function that gets disrupted is the expressive language. We know that Broca's area, which is involved in the articulation of words, is relatively underactive in people when they are listening to a description of the trauma they've suffered when they're being examined in a neural scanner. We equally know that people's capacity to manipulate and recall words is disrupted in post-traumatic stress disorder. So it's not just the external event, it's almost like the internal machinery of expression is disrupted in PTSD. And equally, there are many reminders in a patient's environment which they often don't understand, but will be highly reactive to. And this, I think, is a further example of the need for imaginative engagement. I'll never forget a patient that I had referred to me who'd seen several psychiatrists and 3 psychologists, and he continued to have an extremely severe sleep disturbance. Now, he'd been tried on a range of medications, given a whole lot of strategies for sleep hygiene. And the critical issue was, in fact, what had happened to this man and how going to sleep reminded him of the trauma. He was working on a construction site where there was a huge drainage pipe being sunk into the ground, and the side of the excavation collapsed, and he was buried alive in sand. And he was fortunately very quickly rescued, but he had fractured all the ribs down one side of his chest, as well as his clavicle. Now, why was going to sleep so troubling for him? The first thing is, what is the word that we use when we go to sleep? It's falling asleep. So that sensation was enough to trigger his fear response because it reminded him of falling into the trench. He couldn't sleep in a room without the lights out because darkness reminded him of being buried. He couldn't sleep lying down because that was the posture that he was in when he was covered with the sand. So he would go to sleep in a chair sitting up. Equally, he could not tolerate a blanket over him because the weight of the blanket would remind him of the dirt covering him. And I think that's a very simple example, but it shows you something of what the patient really hadn't recognised was the issue, but equally how the clinicians hadn't heard what he'd said. And I think, one of the privileges of having studied medicine, and in fact probably doing anatomy, where we literally started with a human body on a slab and then had to slowly dissect that body until there was nothing left, was that it did begin to bring your mind into that world of what grotesque mutilation and suffering can be. And that's something that I think many of us naturally want to defend ourselves against. So I think this is a very interesting and important journey you're going to go on with Paula about how you can begin to listen. One last piece of advice. Simply recounting the event does not help people. Even if the individual gets highly distressed, it often leaves them feeling extremely traumatised and troubled. Freud highlighted that the therapeutic benefit, if you are going to recall an event, comes from recalling the details of what transpired in association with the emotion that was experienced. And the critical issue is that it is converted into language. And if you think about it, really that's the essence of most of the techniques that we use in trauma-focused psychotherapy. The job of the therapist is not simply to evoke the distress in the patient. So good luck with your course, and this is a critical aspect of any work that you do. It's fundamental to get these people into evidence-based care rather than simply providing them with support.